Slide 1. Anatomy. We begin our study of macular disease with a review of morphology. The anatomist describes the area centralis as a 6 mm diameter zone extending from near the disc margin to 2 3/4 millimeters temporal to the center of the fovea. Area centralis is that portion of the retina having more than one layer of ganglion cells and is called macula by anatomists. Yanoff and Fine, in their new textbook Ocular Pathology, suggest that the anatomist's macula, or area centralis, corresponds to the clinician's posterior pole. Anatomically, the fovea is a slight depression in the center measuring 1 disc diameter, or 1.5 millimeters. The same area is usually called macula by the clinician. In the very center, a small depression measuring 350 microns, or 1/3 millimeter in diameter, is called foveola. In the foveola, the photoreceptors are pure cones. The anatomical foveola is what the clinician calls fovea. Slide 2. Macular cross-section. In this cross-section diagram, we see the sensory retina includes layers from internal limiting membrane through photoreceptors. 2 retinal capillaries are illustrated to show their location in the inner retinal layers. Moving externally, we encounter retinal pigment epithelium, Bruch's membrane, choriocapillaris, and larger choroidal vessels. Slide 3. Fluorescence. Let us now consider the phenomenon of fluorescence, which refers to the ability of molecules stimulated by one wavelength of light to emit a longer wavelength of light. The excitation peak for the fluorescein molecule is 490 nanometers. This is the wavelength for maximal absorption of light energy. Fluorescein molecules stimulated by this wavelength are excited to a higher energy level to emit a longer wavelength of light with a peak of 530 nanometers. Slide 4. Fluorescein fundus photography. Fluorescein fundus photography takes advantage of the physical properties of the fluorescein molecule as follows. A flash of white light from a retinal camera passes through a blue excitation filter and enters the eye. Blue light strikes and excites fluorescein molecules in retinal and choroidal structures so that yellow-green light emerges from the patient's eye along with blue light. A yellow-green barrier filter then blocks the reflected blue light and permits transmission of only yellow-green wavelengths into the camera where they are recorded on film. Slide 5. Fluorescein binding. Approximately 10 seconds elapse between intravenous injection and the appearance of fluorescein at the posterior pole of the eye. 60% of fluorescein molecules bind to albumin by the time the injected dye bolus reaches the eye. 40% remains unbound as free fluorescein. Free fluorescein molecules pass readily through fenestry of choriocapillaris, while bound fluorescein molecules remain within choriocapillaris, lower right. In retinal circulation, neither free fluorescein molecules nor those bound to albumin pass through intact retinal capillaries, upper right. Slide 6. Pigment epithelium and adjacent structures. At slightly higher magnification, details of retinal pigment epithelium are seen. Unbound or free fluorescein dye particles pass through pore-like structures in the wall of choriocapillaris and through Bruch's membrane, but are stopped by zonula occludens between adjacent retinal pigment epithelial cells. Arrow points to zonula occludens, which is the major barrier to further diffusion of dye particles towards sensory retina. Slide 7. Retinal capillaries. Integrity of retinal capillary endothelial cells, labeled E, with their tight junctions prevents passage of either bound or free fluorescein molecules through retinal vessels. Pericytes, P, and basement membrane, BM, play only a small role in confining fluorescein molecules within lumen of retinal capillaries. When endothelium has been damaged, as in diabetic retinopathy, fluorescein molecules leak freely from retinal capillaries and cause retinal edema, as seen in lower sketch. Slide 8. Normal angiogram. In the normal angiogram, background choroidal fluorescence is usually visible simultaneous with appearance of dye in retinal arteries, upper left. Choroidal fluorescence is seen because unbound fluorescein molecules pass freely through choriocapillaris fenestrae and fill the entire choroidal space in several seconds. This dye ultimately leaves the choroid via the vortex veins. Filling of retinal capillaries occurs 1 or 2 seconds later, upper right, when one also notes laminar filling of retinal veins. Lower left, one sees all retinal veins completely filled with dye, the so-called venous phase. 30 minutes after injection, lower right, essentially no dye is visible in the fundus. Slide 9. Foveal avascular zone. Focusing our attention now on the fovea, a trypsin-digested preparation revealed a capillary-free zone or avascular zone in the central retina, which averages 500 microns or 1/3 disc diameter in size. Recall that the central 350 microns of this retinal avascular zone is an area where the photoreceptors are pure cones. This is the foveola. On the right, a fluorescein angiogram outlines the entire parafoveal capillary network. Later, we shall see how the integrity of the parafoveal blood supply is of prognostic importance in patients with diabetic macular edema and branch retinal vein occlusion. In addition, the parafoveal capillary network is an important landmark when considering patients for photocoagulation treatment. Slide 10. Black macula. Looking again at the central retina, the macula appears darker than the adjacent retina. This is due to reduced background choroidal fluorescence. The diagram on the right demonstrates why this is so. First, xanthophyll in the sensory retina partially blocks the transmission of blue light needed to excite fluorescein molecules in the choroid. Second, the increased density of pigment granules in the retinal pigment epithelium underlying the macula partially blocks the returning yellow-green wavelengths. Both these reasons explain the decreased choroidal fluorescence from the normal macula. Slide 11. RPE window defect. A minor departure from normal is focal loss of pigment in several adjacent pigment epithelial cells, which enhances our view of background choroidal fluorescence, just as raising a shade permits one to see through a clear glass window, thus the name pigment epithelial window defect. Slide 12. Chloroquine retinopathy. A pigment epithelial window defect is illustrated in this patient with chloroquine retinopathy. Note how pigment atrophy enhances the transmission of choroidal fluorescence. Slide 13. RPE window defect. Pigment epithelial window defect may be seen in patients with early drusen of Bruch's membrane. In this 43-year-old lady with 20/20 vision in each eye, note how angiography discloses many more pigmentary abnormalities than one appreciates on the color photographs. During the early phase of the angiogram, upper and lower center, there is marked increase in transmission of choroidal fluorescence through the atrophic changes in the pigment epithelium. 30 minutes after injection, upper and lower right, only a faint glow is visible through pigment epithelial window defects from the very minute amount of dye which persists in the choroid. Slide 14, blocked fluorescence. In contrast to pigment epithelial window defect, where the pigment cells have lost their granules, proliferation of pigment or hypertrophy of pigment epithelium impairs the view of background choroidal fluorescence, similar to lowering the window shade as in our previous metaphor. This patient has background diabetic retinopathy and in addition has hypertrophy of retinal pigment epithelium, which completely obstructs choroidal fluorescence. This is seen schematically on right. Slide 15, congenital hypertrophy of pigment epithelium. This patient demonstrates blocked fluorescence and enhanced fluorescence. She is 43 years old and has congenital hypertrophy of the retinal pigment epithelium surrounding the optic disc. The periphery of the lesion consists of hypertrophied pigment epithelium, inside of which is a scalloped area of atrophic pigment epithelium. The hypertrophied pigment epithelium blocks background choroidal fluorescence, while the atrophic pigment epithelium shows increased transmission of choroidal fluorescence. This is shown schematically upper right. Congenital RPE hypertrophy is a benign lesion. This patient has an enlarged blind spot and 20/20 vision. Slide 16, fluorescence blocked by blood. The presence of blood in any layer anterior to choriocapillaris will also block choroidal fluorescence. This 36-year-old white female experienced sudden loss of vision in the right eye. Examination disclosed 10/200th vision and a posterior vitreous detachment with a large amount of blood beneath the internal limiting membrane. The angiogram shows complete obstruction of choroidal fluorescence by the boat-shaped hemorrhage with fluid level. This blood is beneath the internal limiting membrane, but anterior to the major retinal vessels and blocks fluorescence of retinal vessels as well as from the choroid. Above the fluid level, some blood has dissected posteriorly in the retina and no longer obscures retinal vessels, but continues to block choroidal fluorescence. 3 months later, lower left, most of the blood had reabsorbed and vision had returned to 20/20. Hematologic evaluation was negative. Acute posterior vitreous detachment caused the hemorrhage. The principle of blocked fluorescence by blood is shown schematically lower right. Slide 17, fluorescence blocked by blood. In contrast to preretinal and retinal hemorrhage, blood which is subretinal or subpigment epithelial blocks choroidal fluorescence but actually highlights retinal vascular fluorescence because the black background provides additional contrast. This 54-year-old lady experienced sudden decrease in vision at left eye. Acuity was 20/30 with correction. The color photograph shows a diffuse area of subretinal and subpigment epithelial hemorrhage. The discrete yellow area represents old blood, which has likely been present for several weeks to several months. Symptoms occurred 1 week ago when blood dissected under the macula. In the red-free photograph upper right, note how the extent of subretinal and subpigment epithelial blood is more clearly visible. The angiogram lower left illustrates how subretinal and subpigment epithelial blood completely blocks choroidal fluorescence. This is more extensive than one would appreciate from ophthalmoscopy or examination of the color photograph. The principle of blocked fluorescence by subretinal and subpigment epithelial blood is shown schematically lower right. Slide 18, classification of maculopathies. Before proceeding to a more detailed study of fundus pathology, let us recall that most disorders at the posterior pole can be divided into retinal vascular disorders or problems associated with the pigment epithelium Bruch's membrane choriocapillaris complex. To diagnose a retinal vascular disorder, one must find some abnormality of retinal vessels with ophthalmoscopy, fundus biomicroscopy, or angiography. Similarly, one must observe abnormalities in pigment epithelium before diagnosing a macular disorder as pigment epithelial in origin. Slide 19, serous detachments of macula. To begin our study of pigment epithelial disorders, we consider serous detachment of retinal pigment epithelium and central serous detachment of sensory retina, often called central serous choroidopathy. These are common disorders which frequently require fluorescein angiography for precise definition. In serous detachment of retinal pigment epithelium on left, fluorescein molecules pool beneath RPE, which has become separated from underlying Bruch's membrane. In contrast, serous detachment of sensory retina on right begins as a small RPE detachment. A small break in zonula occludens of pigment epithelium permits sub-RPE fluid to gain access to subretinal space. Slide 20. Serous detachment of pigment epithelium. Small serous detachments of the pigment epithelium may occur in young people and be completely asymptomatic. This 38-year-old man was seen because of symptoms in the right eye. The left eye was asymptomatic. Visual acuity was 20/25. Examination disclosed two small serous detachments of the RPE as seen in the upper three slides. 3 weeks later, with no treatment, visual acuity had returned to 20/20 and the pigment epithelial detachments were flat. The previous RPE elevation resulted in some pigment atrophy, best appreciated as pigment epithelial window defects on the fluorescein angiogram. In a classical serous detachment of the RPE, the entire area of the detachment becomes hyperfluorescent early in the dye transit as free fluorescein molecules pass readily through Bruch's membrane to enter the space beneath the detached pigment epithelium. Continuing into mid-transit phase, fluorescein concentration increases throughout the detachment. Late in dye transit, as most of the fluorescein molecules have emptied from choroidal and retinal circulations, the pooled dye in the subpigment epithelial space remains markedly hyperfluorescent. In long-standing serous detachment of the RPE, focal areas of increased pigmentation frequently occur on the dome of the detachment. These typically take on a propeller or petaloid appearance, and these areas of pigmentation partially block the hyperfluorescence from the underlying RPE detachment in a precise pattern corresponding to the pigment deposition. Slide 21. Serous detachment of pigment epithelium. Serous detachment of RPE in older individuals often, but not always, carries a more serious visual prognosis. This 70-year-old man noted metamorphopsia left eye in January 1973. Vision was 20/30. The color photograph upper left discloses a dome-shaped elevation approximately 4 disc diameters in size. The early fluorescein transit upper right shows uniform pooling of dye beneath the elevated pigment epithelium. 20 minutes after injection, lower left, one sees persistent pooling of dye beneath the elevation with no change in size or shape, a feature characteristic of serous detachment of the pigment epithelium. No treatment was given. 2.5 years later, vision had returned to 20/20 and there was no evidence of serous detachment lower right. The lower right photograph also shows a pigment figure in the center which resulted from the RPE disturbance 2.5 years ago. Slide 22, central serous choroidopathy or retinopathy. In contrast to serous detachment of pigment epithelium, we shall now turn to central serous detachment of the sensory retina, often seen in the form of central serous retinopathy, a common macular disorder which usually involves persons in the 30 to 50 age group. It is heralded by a sudden decrease in central vision and development of metamorphopsia. On examination, one sees a blister-type lesion of the sensory retina, best appreciated on biomicroscopy with a fundus contact lens. This 35-year-old lady presented with 20/50 vision in the right eye. There was definite elevation of the sensory retina upper left. A break in the zonula occludens, shown schematically upper center, permits fluid to accumulate beneath the sensory retina. Early in the angiogram, upper right, there is focal pooling of dye beneath a small RPE detachment. Several seconds later, lower left, dye leaves the subpigment epithelial space and enters the subretinal space through the zonula occludens break. 20 to 30 minutes later, the entire subretinal space begins to fill with dye, lower center and lower right. The majority of patients with central serous retinopathy show spontaneous regression with recovery of visual acuity. Persistent metamorphopsia and Amsler grid defects may remain permanently, however. Slide 23, central serous choroidopathy or retinopathy. 4 years ago, this 29-year-old lady had an episode of visual loss in the left eye which resolved spontaneously in 4 weeks. She now complains of central visual loss in the left eye of 3 weeks duration. Examination reveals 20/40 vision and an elevation of sensory retina. Arnold, would you describe the findings in this patient?
Well, Stuart, on the upper left, we see a focal pigment epithelial detachment at A. Loss of integrity of the pigment epithelium here permits fluid to diffuse and accumulate beneath the sensory retina. On the right, leakage of fluorescein in a smokestack pattern results from thermal convection currents. The retinal pigment epithelial defect at B is the prior episode of serous detachment and permits increased transmission of choroidal fluorescence, but no actual dye leakage. Below, later in the fluorescein transit, there is further leakage of dye beneath the sensory retina. Note the transmission or window defect at B remains unchanged in size.
Slide 24, natural history of central serous retinopathy. Arnold, I think this patient demonstrates the natural history of central serous retinopathy in most young patients. He is a 43-year-old man first seen with a 2-week history of decreased vision in the right eye. Acuity was 20/40 with a central serous detachment of the sensory retina best appreciated on fundus contact lens examination. Early fluorescein upper center showed focal pooling of dye beneath a small RPE detachment. 30 minutes after injection, dye filled the subretinal space. No treatment was advised. 4 months later, his vision was 20/20, although he still complained of some mild metamorphopsia. Fundus examination, lower left, disclosed flattening of the sensory retina. Fluorescein angiography, lower center and right, at approximately the same times as the frames above, showed complete closure of the zonula occludens break with no late pooling beneath the sensory retina. The previous serous detachment of the sensory retina caused some mild atrophic change in the underlying pigment epithelium, seen as subtle pigment epithelial window defects on the mid-transit fluorescein study, lower center. This patient's recovery to 20/20, 4 months after the attack, is rather typical, as is the persistent metamorphopsia, which may be permanent. Slide 25. Serous detachments of RPE and sensory retina. This 40-year-old lady had excellent vision in each eye until 6 weeks prior to examination, when when she noticed slight distortion and a yellow spot centrally in the left eye. Right eye was normal. Left eye vision was 20/40, but improved to 20/30 with +2 diopter sphere. Color photograph upper center shows large circular detachment of sensory retina measuring 4 disc diameters in size. Superotemporal to the fovea, arrows point to 2 discrete pigment epithelial detachments. 20 seconds after dye injection, upper right, note early hyperfluorescence of 2 discrete PE detachments superotemporal to fovea and 1 small PE detachment superonasal to fovea. Lower left photograph, 2 minutes later, shows quadrupling in size of hyperfluorescent area superonasal to fovea, but no change whatever in the 2 isolated RPE detachments superotemporal. 6 minutes later, lower center, note further increase in size of hyperfluorescence superonasal to fovea with faint fluorescein staining of the outline of the sensory retinal detachment temporally and inferiorly. Lower right, 30 minutes after injection, the entire sensory retinal detachment is now visible. Hyperfluorescence from area superonasal to fovea can be traced to the right and downward. Isolated RPE detachments superotemporal to the fovea remain unchanged in size, indicating that they have not contributed to overlying sensory detachment. Fluorescein pooled beneath overlying sensory detachment causes slight blurring of isolated, quiescent pair of RPE detachments superotemporal to fovea. Sequence of photographs illustrates the importance of late angiographic pictures in the study of macular disease. RPE detachment and sensory retinal detachment are seen schematically upper left. Slide 26. Evaluation of sensory retinal detachment. Occasionally, in detachment of the sensory retina, the fluorescein angiogram does not show a focal RPE leak and late accumulation of dye in the subsensory retinal space. The explanation may be that the RPE leak has closed spontaneously while the subsensory retinal fluid still persists. In time, the subretinal fluid will reabsorb and the sensory retina will flatten. Rarely, one may see late accumulation of dye in the subretinal space without a focal RPE leak. Ophthalmoscopy of the posterior pole using a cobalt blue filter may disclose a hyperfluorescent area which represents the focal pigment epithelial leak. The patient shown here had a sensory retinal detachment as seen in the color photograph. Early in the angiogram, upper right, there was diffuse hyperfluorescence in the macular area, but no focal leak. 30 minutes after injection, there was additional dye leakage under the sensory retina, lower left. The small RPE detachment with focal leakage was actually located above the disc, lower right.
Stuart, this is a fascinating patient. Although, as you indicated, this is unusual, it illustrates the desirability of doing indirect ophthalmoscopy with a cobalt blue filter. This should be performed after the initial sequence of photographs of the early dye transit have been taken.
Slide 27. Optic pit. Another cause of central serous detachment of the sensory retina, simulating central serous retinopathy, is optic pit. Optic pit is a colobomatous defect of the optic nerve, occasionally associated with serous detachment of the sensory retina. It may be mistaken for classical central serous retinopathy since both occur in young people. One should always look carefully at the disc and disc margin when evaluating a patient with serous detachment of the macula. The patient illustrated here is 22 years old and vision is 5/200. The sensory retina is elevated and markedly thin due to a long-standing sensory detachment. In the color photograph, note the small round yellow dots, which represent subretinitic precipitates. These are frequently seen in sensory detachments of any etiology. On angiography, also note the atrophic pigment epithelium in the papillomacular bundle. RPE atrophy is also seen with serous detachments. The RPE atrophy is appreciated better in the angiogram as pigment epithelial window defect. Note that 30 minutes after injection, lower center, there is less hyperfluorescence through the window defect in the papillomacular bundle because most dye has left the choroid by this time. Gass has postulated that fluid may enter the subretinal space from either vitreous or from the spinal subarachnoid space. Most authorities subscribe to the latter theory, shown schematically and in histologic section on the right. In many patients, abnormal vessels deep in the pit cause late staining of the pit and nerve head, as seen in this patient. Occasionally, such vessels may actually leak into the subsensory retinal space. Photocoagulation treatment has not been documented to be of benefit. Slide 28. Natural history of senile maculopathy. Let us now turn to senile macular degeneration, a most important cause of visual loss among patients over 50 years of age. It is convenient to divide these cases into non-exudative and exudative maculopathy based on fluorescein angiography findings. Visible leakage of dye beneath pigment epithelium and or sensory retina occurs in the exudative form. Gass, in his pioneer studies on the macula, has emphasized that the primary lesion in senile maculopathy is the drusen body. In some senile eyes, which had only drusen on clinical examination and no dye leakage at angiography, new vessels growing through Bruch's membrane have been found on histologic section. These cases are accounted for in the sketch in the non-exudative section. Proceeding to the right, we enter the exudative stage. Senile breaks in Bruch's membrane allow choroidal neovascularization to proliferate beneath the RPE, and bleeding from these new vessels produces a hemorrhagic detachment of the RPE. Frequently, there is detachment of the overlying sensory retina, which may show cystoid edema. Hemorrhage frequently breaks through the RPE into the subretinal space between sensory retina and RPE, and in occasional cases, the neovascularization grows through the damaged RPE into this space. Patients with subretinal hemorrhage and neovascularization typically progress to a fibrous disciform scar. Many patients develop lipid deposition around the scar, and in some instances, heavy lipid is deposited throughout the posterior pole. Looking more closely at the overall schematic presentation, note that in the non-exudative section, confluent drusen are depicted. These large confluent drusen resemble closely the serous detachment of the RPE. Since there is no dye leakage beneath the sensory retina or pigment epithelium, they are included in the non-exudative section. The size of the arrows gives a general indication of the relative frequency of the different changes that may develop. Note in the inferior row of the exudative stage, a significant number of patients with drusen will progress to serous detachment of the RPE. In some cases, the detachment may flatten spontaneously, or the serous RPE detachment may become vascularized, passing on to the hemorrhagic stages already described. In rare instances, hemorrhagic detachment of pigment epithelium and sensory retina will result in hemorrhage breaking through the sensory retina into the vitreous. Slide 29, drusen. Drusen, which are the primary lesion in senile maculopathy, are thought to be inherited in autosomal dominant fashion. While drusen are commonly seen in the macula of one or both eyes, they may occur throughout the posterior pole and involve peripheral retina as well. In this 40-year-old patient with 20/20 vision in each eye, note drusen appearing throughout the posterior pole. Drusen are seen nasal to the disc and above and below the macula, in addition to the usual appearance in the macula per se. Angiographically, drusen appear as pigment epithelial window defects, but may hold some dye during the later stages of the angiogram as well. Slide 30. Vascularized drusen. This 73-year-old white male showed multiple drusen bodies on routine autopsy examination. In the low-power cross-section on left, vessels containing red blood cells are observed within the drusen. On right, higher magnification of another area showing a vascularized drusen. Note degeneration and loss of pigment overlying the drusen body, which explains the window defect produced on fluorescein angiography. The apparent space between drusen body and sensory retinal elements is a post-mortem artifact. Slide 31. Drusen. Drusen bodies may be small or large. Marked pigment atrophy occurs overlying drusen as seen in upper sketch. This RPE atrophy accounts for increased transmission of choroidal fluorescence as observed in middle sketch. Later in the angiogram, when most fluorescein molecules have left the choroid, some fluorescein remains beneath the drusen and causes late hyperfluorescence noted in lower sketch. Slide 32. Confluent drusen. Larger drusen, particularly when confluent, resemble serous detachment of retinal pigment epithelium. This 51-year-old white male has 20/20 vision in each eye and is entirely asymptomatic. Fundus examination discloses large confluent drusen in the macula of both eyes with marked alteration of overlying pigment epithelium. Both atrophic and proliferative RPE changes are seen. Fluorescein angiography discloses uniform pooling of dye beneath the confluent drusen in the center of the macula in a manner resembling the angiographic appearance of serous detachment of pigment epithelium. The smaller drusen in the periphery are seen as pigment epithelial window defects. Slide 33. Atrophic senile macula. Here we see the non-exudative stage of senile macular degeneration, or what some call dry, atrophic, or central areolar senile macular degeneration. These cases have, in addition to RPE damage, a significant dropout of the underlying choriocapillaris. These patients may presumably never have had an exudative stage, or may have experienced RPE detachments that have flattened spontaneously. This 75-year-old lady has had progressive loss of vision from 2015 down to 2030 over the past 5 years. Initially, she had only drusen. She now has a geographic area of retinal pigment epithelial atrophy. Fluorescein angiogram shows enhanced transmission of choroidal fluorescence due to the marked pigmentary atrophy. Histologically, one would see atrophy not only of pigment epithelium, but of choriocapillaris and photoreceptors as well. This is shown schematically upper right, and in a histologic section from another patient lower right. Slide 34. Serous detachment of pigment epithelium. We now move on to the exudative form of senile maculopathy. Here we see a 70-year-old man with serous detachment of pigment epithelium. Note the entire lesion hyperfluoresces early in the angiogram as fluorescein pools in the subpigment epithelial space. Later in the angiogram, the fluorescent area will remain bright with no change in size or shape. The drusen and atrophic pigmentary changes above the RPE detachment appear as pigment epithelial window defects. Slide 35. Serous detachment of pigment epithelium. Here we see the same patient 30 minutes after dye injection. Fluorescein molecules remain in the subpigment epithelial space after most dye has left the choroid. Dye remaining in the choroid is seen through the multiple pigment epithelial window defects. Slide 36. Serous detachment of pigment epithelium. This 73-year-old man has 20/30 vision. The color photograph, upper left, shows a serous elevation of pigment epithelium with drusen and other atrophic pigmentary changes surrounding the RPE detachment. Fluorescein pools beneath elevated pigment epithelium 12 seconds after injection, lower left. Later, after dye has left the choroidal space, fluorescein molecules remain pooled beneath the elevated RPE, lower right. The proteinaceous material beneath elevated RPE causes slower flow of choroidal fluid in that area and is the likely explanation of the persistence of dye beneath the pigment epithelial detachment. Collection of dye beneath RPE detachment is shown schematically upper right. Slide 37. Choroidal neovascularization. Choroidal neovascular membranes play a prominent role in the pathogenesis of senile maculopathy. This 62-year-old white male was first examined in July 1973, at which time vision was 20/30 OU. The right macula, upper left, shows multiple drusen and a small greenish signet ring lesion beneath the fovea, just behind the fixation pointer. In a 1973 fluorescein study, upper right, the drusen are seen as pigment epithelial window defects, while the signet ring lesion, which is a subretinal neovascular membrane, shows late hyperfluorescence. Because this membrane was immediately beneath the fovea, photocoagulation treatment was not advised. In November 1975, vision had declined to 5/200. There was a large fibrotic subretinal neovascular membrane approximately 3 disc diameters in size, lower left. In the fluorescein angiogram, lower right, note the lacy filling pattern of the neovascular membrane. Slide 38. Choroidal neovascularization. The left eye of this patient suffered a similar fate. Upper left is the left eye in 1973 with 20/30 vision. Hyperfluorescence 30 minutes after injection, upper right, outlines the neovascular membrane. Drusen are seen as RPE window defects. Lower left is the macula in 1975. Vision is now 5/200, and a large choroidal neovascular membrane beneath the fovea shows considerable dye leakage 20 minutes after injection, lower right. Slide 39. Senile choroidal neovascularization. A sensory retinal detachment in a patient over age 50 should alert the ophthalmologist to the possibility of a choroidal neovascular membrane. When one sees blood in the fundus, it is almost certain that neovascularization is present. This 74-year-old white lady noted sudden loss of vision in the right eye. Examination disclosed 20/70 vision with sensory retinal elevation. Arrow points to a rim of blood seen along the perimeter of the elevation. Note blood passes beneath elevated retinal vessels. Drusen are also visible ophthalmoscopically. 12 seconds after dye injection, lower left, note marked hyperfluorescence of neovascular membrane. 30 minutes later, there is pooling of dye in subretinal space, lower right. Note how blood obstructs background choroidal fluorescence. Upper right, note choroidal vessels through Brooks membrane causing leakage of fluid and blood beneath pigment epithelium and sensory retina. Slide 40. Senile choroidal neovascularization. A second clue to the presence of choroidal neovascularization in older patients is the presence of lipid in a patient with apparent serous detachment. This 58-year-old white lady noted sudden loss of vision and was found to have 2200 right eye. The central macula is somewhat out of focus due to sensory retinal elevation. In addition to drusen, arrow points to lipid at base of sensory retinal elevation. On fluorescein angiography, lower left, note early filling pattern of choroidal neovascular membrane immediately beneath the fovea. Blocked choroidal fluorescence just temporal to neovascular membrane represents subpigment epithelial blood, which impairs our view of choroidal fluorescence. This blood is not visible ophthalmoscopically. Fluorescein angiography is much more sensitive than ophthalmoscopy as an indicator of blood beneath retina and pigment epithelium. 30 minutes later, lower right, fluorescein fills the subretinal space. The pathogenesis of this lesion is shown schematically, upper right. Slide 41, senile maculopathy. This 71-year-old white lady saw her ophthalmologist for a routine examination. She was asymptomatic. Vision was 20/70 right eye and 20/15 left eye. Right macula, upper left, has sensory retinal elevation with greenish discoloration centrally, another clue to the possible presence of blood or choroidal neovascularization. With fluorescein, note discrete neovascular membrane just beneath the fovea, upper center, and late pooling of dye beneath sensory retina, upper right. The left eye, lower left, had 20/15 vision, but on fundus examination, arrows point to obvious areas of pigment epithelial alteration. With fluorescein, these areas hyperfluoresce early, lower center, and show persistent hyperfluorescence 30 minutes after injection, lower right. Biomicroscopic examination with a fundus contact lens confirms the angiographic appearance that these are, in fact, serous detachments of the retinal pigment epithelium. Slide 42, senile choroidal neovascularization. Choroidal neovascular membranes may be quite subtle in appearance and may cause no symptoms. This 70-year-old man lost central vision in the left eye 10 years ago and has a disciform macular scar, upper left. In April 1974, the asymptomatic right eye, upper center, had 20/20 vision and showed only mild pigment alterations. In April 1975, 1 year later, eye remains asymptomatic with 20/20 vision, but arrow points to small subretinal hemorrhage in the papillomacular bundle, upper right. Fluorescein, lower left, discloses small choroidal neovascular membrane just above this hemorrhage, which blocks choroidal fluorescence. Marked pigmentary changes appear as window defects. In photograph 6 months later, lower center, arrow points to persistent hemorrhage in the papillomacular bundle. Fluorescein now shows a more discrete choroidal neovascular membrane taking on a signet ring appearance, lower right. Slide 43, serous detachment of pigment epithelium. The next patient demonstrates many components of senile maculopathy. He is 55 years old and has noted decreased vision in the right eye for 6 months. Acuity is 20/40. Color photograph shows a blister of elevated retina in the right macula with some blood in the papillomacular bundle. Note discrete areas of pigment proliferation or pigment migration over dome of the lesion. Early fluorescein frames reveal uniform hyperfluorescence beneath pigment epithelial detachment, lower left. 30 minutes after injection, lower right, the size and shape of fluorescent area is unchanged, a characteristic feature of RPE detachment. Note how pigment migration into the retina over the dome of the detachment creates a hot cross bun or propeller figure and blocks background choroidal fluorescence. In lower left photograph, note also how blood in papillomacular bundle blocks choroidal fluorescence. Although serous detachment of the pigment epithelium in the senile age group should always raise the suspicion of underlying choroidal neovascularization, particularly when blood is present, nothing in this angiogram indicates neovascularization in the macula. The next slide will show us where the blood in the papillomacular bundle originated. Slide 44. Hemorrhagic detachment of pigment epithelium and sensory retina. Here we see the same eye. Upper two photographs are supranasal to disc, and lower two photographs are directly nasal to disc. Upper left, we see elevation of sensory retina and pigment epithelium, subretinal lipid, and considerable subretinal and subpigment epithelial blood. Subpigment epithelial blood usually has a greenish appearance. Upper right, fluorescein of the same area shows a tremendous choroidal neovascular membrane, part of which is obscured by blood. Lower left, note subretinal blood, which on the angiogram lower right completely blocks choroidal fluorescence. Slide 45. Serous detachment of pigment epithelium. This same patient's left eye is asymptomatic and has 20/15 vision. Color photograph shows marked pigmentary abnormalities and a blister of elevation. Fluorescein photograph lower left shows early filling of blister. 30 minutes after injection, lower right, note persistent hyperfluorescence with no change in size or shape of the elevation, a sequence characteristic of serous detachment of the pigment epithelium, shown schematically upper right. Note also how fluorescein angiography discloses many more atrophic pigment epithelial changes seen as pigment epithelial window defects than one can appreciate ophthalmoscopically. Slide 46. Hemorrhagic detachment of pigment epithelium. This 73-year-old man with mild hypertension and diabetes has noticed an irregular streak just above the center of vision in the left eye for approximately 6 weeks. Vision is 20/20. In the color photograph upper left, note small drusen in center of the macula and a crescentic subpigment epithelial hematoma along the inferotemporal arcade. The grayish-green discoloration is the typical appearance of blood beneath retinal pigment epithelium. Fluorescein angiography upper right shows choroidal fluorescence blocked by subpigment epithelial blood and small hyperfluorescent scar just above the choroidal hematoma. 1 month later, lower left, note beginning resolution of subpigment epithelial hematoma. There is granular pigmentation at the inferior edge of the lesion and along the left portion of the crescent. 3 months after initial photograph, lower right, note further resolution of subpigment epithelial hematoma and mottling of pigment in crescentic area of prior hemorrhage. Visual acuity remains 20/20. Slide 47. Peripapillary choroidal neovascularization. This 68-year-old physician has had distortion in central vision left eye for 1 year. Visual acuity is 20/20 right eye and 20/25 left eye. Right macula, upper left, has occasional drusen and mild atrophic pigmentary changes adjacent to disc. These changes appear as RPE window defects on fluorescein study upper center. Photograph of left macula, upper right, shows slight elevation of peripapillary sensory retina with lipid deposition. Note small area of subpigment epithelial hemorrhage extending from 3 to 4 o'clock along disc margin. The presence of lipid and blood in an older patient alerts us to the probability of finding choroidal neovascularization with angiography. In fluorescein transit, lower left, area of subpigment epithelial hemorrhage blocks choroidal fluorescence. Hyperfluorescent area shows neovascularization that is visible beyond the edge of hemorrhage. 1 minute later, lower center, note increase in size and intensity of subretinal neovascular membrane. 30 minutes after injection, fluorescein fills subretinal space. This patient received no treatment. 4 years later, vision remains 20/25 and neovascular membrane is unchanged in appearance. Slide 48. 15-year follow-up of senile macula. In 1960, this 62-year-old white male developed classical senile disciform macular degeneration in the right eye with permanent impairment of central vision. At this time, the left eye showed scattered drusen. In December 1967, the patient developed an acute exudative maculopathy in the left eye. Fundus photograph upper left, note large drusen scattered throughout the posterior pole, central pigment epithelial detachment, and surrounding lipid deposits. 9 months later, in August 1968, upper center, color photograph shows breakthrough of subretinal hemorrhage beneath sensory retina. In fluorescein study done in August 1968, note subretinal neovascular membrane, arrows. Blood at border of membrane blocks underlying choroidal fluorescence. Lower left, 3 months later, November 1968, large hemorrhagic detachment and surrounding blood are resolving. Lipid deposition in overlying sensory retina is prominent. 1 year later, lower center, November 1969, resolution of blood and pigment epithelial detachment and replacement with fibrous tissue. Lower right, 6 years later, December 1975, dense fibrous scar is present. Note pigment proliferation and retinal vessel dipping into subretinal scar to presumably anastomose with choroidal circulation. Arrow. Slide 49. Choroidal neovascularization beneath apparent serous detachments of pigment epithelium. Upper left photograph, right eye, shows a large serous detachment of retinal pigment epithelium in a 76-year-old white male. Upper center, fluorescein shows large serous detachment of RPE, but in addition, arrow points to focal area of neovascularization. Upper right, late fluorescein shows complete filling of pigment epithelial detachment. Lower left, fundus photograph of left eye, large pigment epithelial detachment with heavy lipid deposition. Lower center, fluorescein angiogram shows large pigment epithelial detachment and area of choroidal neovascularization. Lower right, 10 minutes after injection, pooling of dye beneath large pigment epithelial detachment. This case illustrates the combination of choroidal neovascularization with a large detachment of the RPE in each eye. Slide 50, subretinal neovascularization and vitreous hemorrhage. This is a 69-year-old man with a 6-month history of visual loss in the left eye. Right eye vision is 20/20 despite marked pigmentary abnormalities and a plethora of drusen bodies, upper left. Left eye vision is 3/200. Fundus, lower left, shows large hemorrhagic detachment of pigment epithelium and sensory retina. 2 months later, lower right, vision had gone to hand motion as a result of vitreous hemorrhage. Vitreous hemorrhage from choroidal neovascularization is shown schematically, upper right. Slide 51. Ocular histoplasmosis. The presumed ocular histoplasmosis syndrome was first described by Woods and Whalen in 1959. In the fundus, one sees peripapillary atrophy, peripheral atrophic scars, and macular lesions. A wide spectrum of fundus abnormalities is encountered. Photographs on the left show that changes around the disc vary from a small atrophic area to total peripapillary atrophy. Peripheral lesions vary from small yellow atrophic spots to larger scars with hyperpigmented borders as seen in the center pictures. In the macula, there may be one or more atrophic spots, choroidal neovascularization with sensory retinal detachment and hemorrhage, or a large disciform scar, as seen in the photographs on the right. Any combination of these findings may be observed. Slide 52. Natural history of ocular histoplasmosis. Skin test reactivity to histoplasma antigen, particularly among inhabitants of the Ohio River Valley, indicates that the number of persons who have had prior exposure to Histoplasma capsulatum is far in excess of the number of patients with visual complaints. Macular involvement presumably begins with an area of focal choroiditis, upper left, involving choriocapillaris and Bruch's membrane, which ultimately causes some atrophy of the overlying pigment epithelium. Eventually, this becomes a quiescent scar or histospot, as in the upper center sketch. 10 to 30 years later, further changes in Bruch's membrane permit choroidal blood vessels to gain access to the subpigment epithelial space, upper right. Gass has postulated that constant vascular bombardment from the short posterior ciliary arteries accounts for the predilection of the macula to develop neovascular membranes from such atrophic macular scars. Subsequently, the choroidal neovascularization may bleed beneath pigment epithelium, as seen lower right. Later, the vessels may break through the pigment epithelium and occupy the subretinal space, leading to sensory retinal detachment and cystoid macular edema, lower center. Ultimately, a fibrous disciform scar occurs, as seen lower left. Slide 53. Pathogenesis of neovascularization in histoplasmosis. The development of a choroidal neovascular membrane from an atrophic macular scar may be preceded by progressive change in the size and pigmentation of the scar. The patient shown here is a 55-year-old white lady who lost central vision right eye in 1969. Left eye vision was 2015. Photograph upper left shows many histospots in the left macula. From 1971 to 1975, she had several episodes of metamorphopsia in the left eye, each of which was associated with a subtle change in the size of the same spot. At no time was blood or lipid seen, and at no time did the fluorescein angiogram show a choroidal neovascular membrane. Color photographs upper center and upper right, taken in 1972 and 1974 respectively, illustrate the progressive changes seen in this atrophic spot. In August 1975, the patient noticed a definite reduction in vision and was found to have 20/50 left eye. Fundus lower left now showed subretinal blood and a sensory retinal detachment adjacent to the changing histospot. Fluorescein at this time showed a definite choroidal neovascular membrane, lower center, which leaked dye into the subretinal space, lower right. In summary, this patient demonstrates the development of choroidal neovascularization from an atrophic macular scar over a 4.5 year period. Slide 54. Pathogenesis of neovascularization in histoplasmosis. The development of choroidal neovascularization from an atrophic macular scar can occur more rapidly than illustrated in the previous patient. This 22-year-old white male was initially seen April 11, 1975 because of a symptomatic macular hemorrhage in the left eye. Examination of the right eye at that time revealed 20/15 vision. The macula was normal except for the 3 small atrophic scars temporal to the fovea, upper left. There was no ambler grid distortion, and the sensory retina was flat with fundus contact lens examination. No blood or lipid was seen. Fluorescein angiography during early dye transit, upper center, showed increased transmission of choroidal fluorescence through the atrophic pigment epithelial changes overlying these histospots. 30 minutes after injection, upper right, some hyperfluorescence is seen through the atrophic pigment epithelium, but there is no change in the size or shape of these spots. Exactly 33 days later, on May 13, 1975, the patient noted metamorphopsia in the previously asymptomatic right eye. Although vision remained 20/15, there was definite ambler grid distortion nasal to fixation. The fundus now showed a blister of elevated retina with subretinal hemorrhage adjacent to one atrophic histospot, lower left. Fluorescein angiography showed a discrete choroidal neovascular membrane from one of the histospots, lower center, with late pooling of dye beneath the elevated sensory retina, lower right. This case illustrates the development of a symptomatic choroidal neovascular membrane from an asymptomatic macular histospot in a period of 1 month. Slide 55. Progression of histoplasmic neovascular membrane. The previous patient illustrated rapid development of choroidal neovascularization from an atrophic macular scar. Here we see rapid enlargement of an existing choroidal neovascular membrane. This 24-year-old white female presented in November 1973 with 20/30 right eye. Fundus examination showed typical presumed ocular histoplasmosis syndrome. In November 1973 angiogram, upper and lower left, note 2 discrete patches of choroidal neovascularization just temporal to the fovea. 3 weeks later, vision remained at 20/40, but note quadrupling in size of the superior neovascular membrane, upper and lower center. 1 year later, upper and lower right, note neovascular membrane now extends immediately beneath the fovea. Vision has remained 20/50 for 2 years despite subfoveal neovascularization. Slide 56. Peripapillary choroidal neovascularization. Choroidal neovascularization in ocular histoplasmosis may occur around the disc. Because of its distance from the fovea, subretinal neovascularization in the peripapillary area carries a better visual prognosis than in the paramacular area. This 44-year-old plastic surgeon noticed sudden distortion in the right eye. Vision was 20/40. In the upper left photograph, note subretinal blood, lipid, and wrinkling of the internal limiting membrane through the macula. Fluorescein angiography, upper center, demonstrates a choroidal neovascular membrane partially obscured by blood located just beneath the supratemporal retinal vessels. Late photograph, upper right, shows pooling of dye beneath the sensory retina. No treatment was advised. 3 months later, vision returned to 20/20. The lower 3 photographs show complete resolution of the subretinal blood, considerable resolution of lipid, and reduction in the degree of retinal wrinkling. Vision has been maintained at 20/20 for 18 months. Slide 57. 6-year follow-up of choroidal neovascularization. This 49-year-old white male lost central vision in the left eye in 1969 due to hemorrhagic macular detachment, upper left. Vision in the right eye was 20/15 at that time. Macular exam, lower left, showed shallow sensory retinal elevation due to a choroidal neovascular membrane, center photographs. During the next 6 years, he experienced several episodes of metamorphopsia in the right eye, but at no time did acuity fall below 20/30. Photographs on the right are taken in 1975, at which time the appearance is virtually unchanged from the 1969 pictures. Slide 58. Eccentric choroidal neovascularization in histoplasmosis. The vast majority of choroidal neovascular membranes in ocular histoplasmosis develop in the vicinity of the macula. Rarely one sees a patient with an eccentric focus of active neovascularization. There may be many patients who have such eccentric foci, but who never come to clinical attention because the distance of the process from the fovea keeps the episode entirely asymptomatic. This 63-year-old white lady noticed floaters in the left eye and reported to her ophthalmologist for evaluation. Visual acuity was 20/15. There was evidence of peripapillary atrophy, upper left, and one peripheral atrophic spot was seen, upper center. A single atrophic spot was seen adjacent to the disc, upper right, but the main focus of activity was beneath the left macula where a hemorrhagic lesion was observed, lower left. fluorescein angiography disclosed an active choroidal neovascular membrane, lower center, with late leakage beneath the sensory retina, lower right. Since visual acuity was 2015, and since this neovascular membrane was located at some distance from the fovea, no treatment was recommended. Over a 3-month period of time, the neovascular membrane closed spontaneously, the hemorrhage and lipid reabsorbed, the retina flattened, and she has remained asymptomatic for 1 year. Slide 59. Photocoagulation of histoplasmic neovascular membrane. This 42-year-old physician with ocular histoplasmosis lost central vision in the left eye 10 years ago. He presented with a 1-week history of decreased vision and metamorphopsia in the right eye. Visual acuity was 20/25. There is an elevated area of sensory retina and pigment epithelium just temporal to the fovea. The fluorescein sequence shows the fine lacy filling pattern of the choroidal neovascular membrane. Note late pooling of dye in the subretinal space, lower center. This neovascular membrane was outside the capillary-free zone and 1/4 disc diameter from the center of the fovea. The patient was treated with argon laser photocoagulation. Note intensity of treatment lesions. Slide 60. Photocoagulation of choroidal neovascular membranes. Arnold, would you outline your approach to the management of choroidal neovascular membranes?
Stuart, I always use retrobulbar anesthesia, as intense photocoagulation is necessary to obliterate the neovascular membrane. Inadequate photocoagulation may be worse than no treatment at all. The retrobulbar anesthesia assures that neither patient discomfort nor ocular motility will compromise the success of treatment. I begin with a row of 50 micron spots placed 125 microns or 1 vein width past the foveal edge of the neovascular membrane. This provides a visual landmark to prevent inadvertent photocoagulation of the fovea. Next, the foveal side of the neovascularization is treated with overlapping 100 micron lesions at 0.2 to 0.5 seconds. The foveal side is treated first, so that if hemorrhage occurs, it will be away from the fovea. Finally, overlapping 200 micron lesions at half-second exposures are used to obliterate the neovascularization. Weekly fundus examination and fluorescein studies are done until we are certain that the neovascularization has been completely destroyed.
Slide 61. Criteria for photocoagulation of choroidal neovascularization. Arnold, I think it is important to emphasize the value of the parafoveal capillary network as a landmark in determining whether or not a choroidal neovascular membrane can be considered for photocoagulation treatment. Although there is variation, the average retinal capillary-free zone has a 500 micron diameter or a 250 micron radius. The optic disc measures 1500 microns, and the width of a vein crossing the disc measures 125 microns. The distance between the center of the capillary-free zone, which is the center of the fovea, and one vein width, or 125 microns past the edge of the capillary-free zone, is 375 microns, or 1/4 disc diameter. Photocoagulation of choroidal neovascular membranes closer than 1/4 disc diameter from the center of the fovea carries significant risk of damaging central vision permanently. Therefore, we have reserved photocoagulation for patients whose neovascularization lies at least one vein width or 125 microns past the edge of the retinal capillary-free zone. In the schematic upper left, note neovascularization inside the capillary-free zone not amenable to treatment. Lower left, neovascular membrane extends to the edge of the capillary-free zone. To obliterate a neovascular membrane, intense photocoagulation lesions should extend one vein width beyond the actual neovascularization. Therefore, we do not recommend treatment for the patient illustrated lower left because photocoagulating one vein width beyond the neovascularization would place lesions inside the capillary-free zone and destroy photoreceptors in the foveola. In contrast, upper right and lower right are neovascular membranes that would be amenable to photocoagulation because of their location at least one vein width past the edge of the retinal capillary-free zone. Slide 62. Post-photocoagulation angiogram. Looking again at our physician with histoplasmosis, a photograph 1 year following treatment shows marked atrophy of pigment epithelium and choriocapillaris. In the fluorescein study, no typical late staining at edge of scar, lower right, but no evidence of choroidal neovascularization. The sensory retina was flat on fundus contact lens examination. Vision remains 20/25, 3 years after treatment. There is a dense but not disabling paracentral scotoma. Despite the successful outcome in this patient, the benefit of photocoagulation for histoplasmic neovascular membranes has not been documented in a controlled trial. Slide 63. Idiopathic choroidal neovascularization. Choroidal neovascular membranes may occur in the macula unassociated with a specific etiology. The upper three photographs illustrate the findings in a 24-year-old white lady with osteogenesis imperfecta. She noticed a sudden loss of vision one day and was found to have 20/15 right eye and 5/200 left eye. There was no history of trauma and no significant family history. The color photograph shows sensory retinal elevation with subretinal blood. Note the filling pattern of the choroidal neovascular membrane and the late leakage beneath the sensory retina on the fluorescein angiograms upper center and upper right. There were no disc changes or peripheral atrophic spots as one would see in presumed ocular histoplasmosis. No connection between the fundus findings and osteogenesis imperfecta was established. Below are photographs from a 14-year-old girl who also experienced sudden loss of vision in the left eye and was found to have 10/200 acuity. Note the typical greenish discoloration of new vessels beneath retinal pigment epithelium. Note also subretinal blood surrounding this lesion. Fluorescein lower center and lower right illustrates the filling pattern of the choroidal neovascular membrane. No etiology was established. Slide 64. Myopic retinopathy with choroidal neovascularization. Choroidal neovascularization may develop whenever there is a break in the continuity of Bruch's membrane. We have already seen choroidal new blood vessels in the senile macula, in presumed ocular histoplasmosis, and on an idiopathic basis. We shall now look at choroidal neovascularization in a highly myopic eye with extensive changes in Bruch's membrane. This 24-year-old black male with a refractive error of -12 experienced sudden loss of vision in the left eye. Right eye vision had been reduced for several years. Acuity was 2200 right and 20/20 left. On the left, note peripapillary staphylomas in both eyes. In the center, note multiple yellow lacquer cracks and a greenish lesion in the central retina. Fluorescein angiography on the right shows increased transmission of choroidal fluorescence through the lacquer cracks, which are really atrophic changes in Bruch's membrane and pigment epithelium, and a discrete choroidal neovascular membrane in each macula, which corresponds to the green lesion seen in the color photographs. Since the neovascular membrane was directly subfoveal on the right and encroached on the retinal capillary free zone on the left, photocoagulation treatment was not advised. Slide 65. Myopic retinopathy with choroidal neovascularization. This 64-year-old white female lost central vision in the right eye 20 years ago. Visual acuity has stabilized at 2200. The red-free photograph upper left shows an atrophic staphylomatous lesion in the right macula, which appears as a transmission defect in the fluorescein study upper right. The left eye had a recent decline in vision to 2100. The color photograph lower left shows marked distortion of the normal macular vascular landmarks. A hemorrhagic lesion is seen approximately in the area where the fovea is usually found. Fluorescein lower right shows a choroidal neovascular membrane corresponding to this hemorrhagic lesion. Slide 66. Optic nerve drusen. Optic nerve drusen are congenital abnormalities which are found in 2% of eyes on routine autopsy examination. The color photographs on the left show the right and left discs of a 7-year-old white boy who noted an acute decrease in vision in the right eye. The hemorrhagic lesion in the papillomacular bundle of the right eye will be described in the next slide. The irregular disc margins are sometimes referred to as pseudopapilledema. The irregular disc margins are better appreciated on the fluorescein angiogram. It was difficult to identify specific drusen bodies with ophthalmoscopy, but they were seen readily on fundus biomicroscopy. Examination of family members of patients with optic disc drusen often disclose drusen in a parent or sibling, since these are thought to be inherited in autosomal dominant fashion. Upper right is a histologic section taken from another patient, which shows deposition of material in the optic nerve. The artist's sketch, lower right, illustrates choroidal neovascularization in association with optic nerve drusen. Slide 67. Optic nerve drusen with neovascularization. This is the same patient seen in slide 66. Let us examine more carefully the hemorrhagic lesion in the papillomacular bundle of the symptomatic right eye. In the color photograph, greenish discoloration with surrounding subretinal blood, pigment epithelial atrophy, and lipid along the perimeter of the sensory retinal elevation suggest the presence of choroidal neovascularization. Fluorescein 10 seconds after injection, upper right, discloses 2 vessels passing from the disc toward the choroidal neovascular membrane. Stereoscopic examination of the angiogram showed clearly that the upper vessel was a feeder vessel to the choroidal neovascular network, whereas the lower vessel was in the plane of the retina and was clearly a retinal vessel. Fluorescein lower left, 40 seconds later, shows further filling of the neovascular membrane. Lower right, 30 minutes after injection, dye has filled the subsensory retinal space. No treatment was recommended, and vision has been maintained at 20/40 during the 6 months that he has been followed by his referring physician, Dr. William Hagler of Atlanta. Slide 68. Choroidal rupture. Direct or indirect trauma to the globe frequently produces choroidal rupture. The choroidal tears usually occur concentric to the disc and often between the fovea and the disc. The rupture involves Bruch's membrane and choriocapillaris and occasionally full-thickness choroid as well. Sensory retina is usually intact. Pigment epithelium overlying the tear often becomes atrophic. These changes are illustrated in the sketch upper left. This patient sustained direct trauma to the globe and has multiple tears of Bruch's membrane and choroid on the temporal side of the disc. The tears are seen as yellow streaks in the color photograph. The subretinal and subpigment epithelial blood produced by the choroidal rupture blocks background choroidal fluorescence as illustrated in the angiograms below. Slide 69. Choroidal rupture with subretinal neovascularization. Usually the edges of a choroidal tear seal down, and if the foveola is not involved, the patient may recover central vision. Occasionally a choroidal neovascular membrane will develop through the break in Bruch's membrane. This 52-year-old white male sustained a tennis ball injury to the left eye. Examination disclosed a choroidal rupture and several peripheral retinal breaks. Cryotherapy was applied to the retinal breaks. 9 months later, the patient complained of considerable metamorphopsia. Examination disclosed elevation of the sensory retina overlying the choroidal tear. In the color photograph, note the pigmentary changes adjacent to the break in Bruch's membrane. In the early angiogram, lower left, note the neovascular membrane in the center of the choroidal break. 30 minutes after dye injection, lower right, there is definite leakage into the subretinal space from the choroidal neovascular membrane. This is seen schematically, upper right. Slide 70. Choroidal neovascularization in angioid streaks. Angioid streaks, which represent breaks in Bruch's membrane, are seen most commonly as part of pseudoxanthoma elasticum, a systemic disease with autosomal recessive inheritance. This 22-year-old girl has obvious streaks radiating from the optic disc, upper left. Pigment proliferation overlying the streaks blocks choroidal fluorescence, upper center. In some instances, there may be interruption in the underlying choriocapillaris, which contributes to the hypofluorescence of some streaks, as seen in the sketch, upper right. In other areas, where RPE becomes atrophic overlying the streaks, there is increased transmission of choroidal fluorescence due to the window defects produced. This patient experienced sudden decrease in vision right eye. Acuity was 20/40, and fundus examination, lower left, shows a serous detachment of the macula. Fluorescein, lower center, shows two discrete choroidal neovascular membranes within a streak just inferior to the fovea. Subretinal blood can be seen just temporal to the neovascularization. 30 minutes after injection, dye accumulates in subretinal space, lower right. Slide 71. Angioid streaks. This 32-year-old white female with pseudoxanthoma elasticum exhibits many ophthalmoscopic features which have been described in patients with angioid streaks. In photographs upper and lower left, note streaks radiating 360 degrees from both optic discs. She also has bilateral optic nerve drusen, which have been reported in association with angioid streaks. Right eye vision is 5/200 because of an old disciform macular scar, upper center. Left eye vision has recently declined to 20/30. Fundus, lower center, shows sensory retinal elevation from two choroidal neovascular membranes which have characteristic green coloration. The upper right photograph illustrates salmon spots which have not been studied histopathologically but which may represent end-stage focal choroidal hemorrhages. Lower right, note diffuse pigmentary changes, sometimes called peu d'orange, because of the similarity in appearance to the skin of an orange. Slide 72. Development of choroidal neovascularization in angioid streaks. This is the left eye of the 22-year-old girl, whose right eye was seen in slide 70. The upper photographs were taken in June 1974 when visual acuity was 20/15 in the left eye. Note the streak which passes immediately inferior to the fovea on both the color photograph and the fluorescein angiogram. In September 1975, 15 months after the upper photographs were taken, she noted an acute decrease in vision and was found to have 20/40 acuity on examination. At this time, the fundus showed a serous detachment of the macula with subretinal blood, as seen lower left. Fluorescein, lower right, shows a discrete choroidal neovascular membrane growing through the streak which passes immediately inferior to the fovea. More than 75% of patients with angioid streaks have macular involvement, and many develop choroidal neovascular membranes through the discontinuity in Bruch's membrane, which constitutes the streak. Slide 73. Traumatic macular hemorrhage with angioid streaks. We now recognize that ocular trauma plays a significant role in the pathogenesis of visual loss in some patients with angioid streaks. This 30-year-old white male has had poor vision in the right eye for many years because of a macular scar upper left. In early 1972, he experienced sudden loss of left eye vision after receiving a blow to the globe during a basketball game. On examination, vision was 20/70. Upper center notes subretinal hemorrhage in the papillomacular bundle adjacent to an angioid streak. Fluorescein disclosed a choroidal neovascular membrane upper right with pooling of dye beneath the sensory retina several minutes after injection, lower left. Over the next year, the blood reabsorbed and he was left with a pigmented macular scar, lower center. Vision has remained 2100. Peripapillary streaks are readily visualized in fluorescein photograph of the disc, lower right. In 1972, we found that 7 of 28 patients with angioid streaks and sudden visual loss had experienced trauma to the globe or periorbita within 24 hours prior to visual loss. Breaks in Bruch's membrane may render such eyes more susceptible to traumatic macular hemorrhage than normal eyes. For that reason, we recommend that patients with angioid streaks refrain from contact sports and from other activities which are likely to be associated with trauma to the globe. Slide 74. Acute multifocal posterior placoid pigment epitheliopathy. Acute multifocal posterior placoid pigment epitheliopathy was first described by Gass in 1968. It may be preceded by an upper respiratory infection. In some cases, serologic evidence of central nervous system infection has been found on spinal fluid examination. Ophthalmoscopically, there are diffuse changes in retinal pigment epithelium in the form of yellowish placoid lesions which occur predominantly at the posterior pole but may extend out to the equator. With a fundus contact lens, the lesions seem to be at the level of the retinal pigment epithelium. Neither lipid, blood, nor elevation of pigment epithelium or sensory retina is seen. Early in the angiogram, the placoid lesions obstruct background colloidal fluorescence. Later in the angiogram, the placoid lesions may stain with fluorescein due to alteration in the integrity of the RPE, which permits dye molecules to enter the cells. These concepts are illustrated schematically upper right. Deutschmann has postulated that choriocapillaris, rather than pigment epithelium, is the primary site of inflammation. Choriocapillaritis with capillary closure would explain the decreased colloidal fluorescence in the early angiogram. Secondary involvement of RPE might then explain late hyperfluorescence. The exact nature and location of the inflammatory process awaits clinico-pathologic correlation. The patient illustrated is a 22-year-old white female whose vision fell to 20/40 in the right eye. Note multiple yellow placoid lesions at the posterior pole, upper left. Early in the angiogram, note obstruction of colloidal fluorescence by placoid lesions. Later, in the same angiogram, these same lesions hyperfluoresce, lower left. Slide 75. Acute multifocal posterior placoid pigment epitheliopathy. This is the left eye of the same patient seen in slide 74. Vision is 2200 and the lesions are somewhat older. Note obstruction of colloidal fluorescence in early frames, upper right and lower left, and late staining of lesions, lower right. Slide 76. Retinal pigment epitheliitis. Retinal pigment epitheliitis is presumed to be a viral infection of retinal pigment epithelium in the macular area. It is usually bilateral and characterized by a modest loss of visual acuity, rarely worse than 20/30. Ophthalmoscopically, one sees atrophic retinal pigment epithelium, which appears as pigment epithelial window defects on fluorescein angiography. This is a 30-year-old white male with metamorphopsia in both eyes. Acuity is 20/20. On the color photographs, note atrophic RPE changes in the macula of both eyes. Fluorescein angiography during early dye transit, upper and lower center, illustrates increased transmission of colloidal fluorescence through the pigment epithelial window defects. Fluorescein frames 30 minutes after dye injection, upper and lower right, show no dye leakage in or beneath the sensory retina. This patient has been followed for 3 years and maintains 20/20 vision in both eyes. Slide 77, retinal pigment epitheliitis. This is a 32-year-old physician who experienced metamorphopsia in the left eye only. Right eye vision was 20/15 and left eye vision was 20/20 with angular grid distortion. Sensory retina was flat. The color photograph illustrates atrophic RPE change centrally. 15 seconds after fluorescein injection, upper right, note increased transmission of choroidal fluorescence through RPE window defects. Lower left, note persistent hyperfluorescence through RPE window defects 2 minutes after injection. 30 minutes later, lower right, there is no evidence of persistent hyperfluorescence after dye has left the choroid. Slide 78, macular hole. Macular hole occurs not uncommonly in older individuals without evidence of vitreous traction or retinal vascular disease. The pigment epithelium beneath the hole becomes atrophic and permits enhanced visibility of the choroidal vessels, resulting in the appearance of a cherry red spot in the macula. This 69-year-old lady noted decreased vision in the right eye when covering the left eye. Acuity was 2200. Note the cherry red spot on the color photograph. The increased choroidal fluorescence through the macular hole seen during early dye transit, upper right, is due to atrophic pigment epithelial change and also to the loss of xanthophyll from the outer retinal layers. Recall that xanthophyll ordinarily impairs the passage of blue light from the camera to fluorescein dye molecules in the choroid. Recall also that pigment epithelium blocks passage of yellow-green wavelengths from fluorescein in the choroid towards the camera. The absence of the xanthophyll and the atrophy of pigment epithelium both explain the increased hyperfluorescence during dye transit. 30 minutes after dye injection, lower left, no dye can be seen in the choroid. The explanation for enhanced visualization of choroidal fluorescence with a macular hole is illustrated schematically lower right. Slide 79, pre-retinal macular fibrosis. Wrinkling of the internal limiting membrane of the retina occurs in patients with diabetic retinopathy, branch vein occlusion, and other disorders. It may also occur without apparent cause and has been described as pre-retinal macular fibrosis by Wise and Henkind because histologic studies show a sheet of fibrous cells proliferating along the internal surface of the internal limiting membrane, as seen in the histologic section, courtesy of Dr. W. Richard Green, upper left, and in the artist's drawing, lower left. Most patients are over age 50, and few have serious visual disabilities, although some will have visual acuity reduced to 2200. 20% of the cases are bilateral. The posterior vitreous is usually detached and plays no definite role in the pathogenesis of this disorder. The patient illustrated is a 62-year-old white man whose vision is 20/40. In the color photograph, note tortuosity of the retinal vessels passing through the macula. The pre-retinal membrane is appreciated better on the red-free photograph, lower center. Fluorescein, upper right, outlines clearly the tortuous retinal vessels. Traction on retinal vessels by the membrane frequently produces some alteration in the integrity of the endothelial cells and results in some late leakage of fluorescein, often in a cystoid pattern, as seen lower right. Slide 80, pre-retinal macular fibrosis. This is a 65-year-old lady who one day noticed distortion and was found to have 2200 right eye and 20/20 left eye. Photographs of the right macula above show the characteristic sheen of a pre-retinal membrane. Retinal vessel tortuosity is appreciated on the fluorescein upper right. This patient's asymptomatic left eye with 20/20 vision is seen in the photographs below. The retinal vascular tortuosity alerts one to the presence of a pre-retinal membrane even in an asymptomatic eye. The sheet of cells anterior to the internal limiting membrane that is responsible for the traction on retinal vessels is shown schematically lower right. Slide 81. Pre-retinal macular fibrosis with cystoid macular edema. This 63-year-old physician complained of a 2-year history of decreased vision in the left eye. He was referred for evaluation of idiopathic cystoid macular edema. Examination disclosed 20/30 vision. The red-free photograph, upper left, illustrates a pre-retinal macular membrane. Fluorescein angiography 20 seconds after injection, upper right, shows moderate vascular tortuosity. 35 seconds after injection, lower left, note early leakage from retinal vessels. 30 minutes after injection, lower right, note typical petaloid pattern of cystoid macular edema. Slide 82. Pre-retinal macular fibrosis. This patient illustrates the most advanced changes and the most severe loss of visual acuity that we have seen from pre-retinal macular fibrosis. He is 55 years old and has noted progressive decrease in visual acuity in the left eye for 1 year. The right eye is asymptomatic. Left eye vision is 15/200ths. The upper photographs illustrate a large pre-retinal membrane temporal to the macula with marked retinal vascular tortuosity. The lower photographs show that in addition to retinal edema, traction on the retinal vessels has actually caused retinal hemorrhages. Note how these hemorrhages block colloidal fluorescence on the angiogram lower right. Slide 83. Pre-retinal macular fibrosis with posterior vitreous traction. In George Wise's series of 150 eyes with pre-retinal macular fibrosis, 120 had posterior vitreous detachment. Wise stated that in only one eye was he able to find an adhesion between the posterior hyaloid and the retina, and this finding was equivocal. This 42-year-old man represents the only instance in which we have been able to document a fibrous band from a posterior vitreous detachment to the area of internal limiting membrane wrinkle. The color photograph illustrates the tortuosity of the retinal vessels characteristic of internal limiting membrane shrinkage. The slit lamp photograph illustrates the band from the detached vitreous to the retinal surface. This attachment is seen schematically in the sketch. Slide 84. Traumatic pre-retinal macular fibrosis. Occasionally, trauma is the underlying etiology of apparent idiopathic pre-retinal macular fibrosis. This 7-year-old boy was found to have 2100 in the left eye on a routine examination. His mother stated that he had had a black eye 2 years ago after being struck with a belt buckle. There was no apparent evidence of intraocular injury at the time. Note marked retinal vascular tortuosity upper left. With a fundus contact lens, there was marked condensation of the posterior hyaloid in front of the macula. Fluorescein angiography highlights the tortuous retinal vessels seen on fundus examination. Slide 85. Fundus flavimaculatus. Fundus flavimaculatus is one of the more commonly occurring juvenile macular degenerations. Autosomal recessive is the usual mode of inheritance, although autosomal dominant and sex-linked inheritance have also been reported. The presence of atrophic flecks, often in the shape of a fishtail, is the cardinal ophthalmoscopic feature. In some patients, only these atrophic flecks are seen, and unless one of the flecks involves the center of the fovea, visual acuity is not affected. More commonly, atrophic flecks are seen in association with an atrophic maculopathy. Either the peripheral flecks or the macular lesion may begin first. The combination of atrophic maculopathy with flecks is the condition described many years ago by Stargardt. Central vision frequently falls to 2200 or worse in both eyes. In some patients, a retinitis pigmentosa-like picture with peripheral retinal vascular narrowing and pigment migration into the retina may occur late in the course of the disease. At this stage, there may be profound constriction of visual fields and reduced night vision in addition to the atrophic flecks and macular lesions. This 17-year-old girl has had poor vision since early childhood. At age 10, she was found to have 2200 in either eye. Vision has subsequently deteriorated to 5200 in each eye. In the color photographs, note the atrophic macular lesions and the fishtail-shaped flecks throughout the posterior pole. Fluorescein angiography of the same areas shows that the flecked lesions appear as pigment epithelial window defects. In one histologic case, reported by Krill, deposition of mucopolysaccharide was seen in the apical portion of the pigment epithelial cell. There is no known treatment. Slide 86. Fundus flavimaculatus. This 54-year-old white lady gave a history of poor vision in both eyes for more than 30 years. She had been evaluated on many occasions and given multiple diagnoses, including histoplasmosis and toxoplasmosis. We learned that her sister also had poor vision and subsequently determined that this sister had the same condition. Visual acuity is 2400 in each eye. Note the profound atrophy in the macula of both eyes above. Note also the atrophic flecks throughout the posterior pole, similar to the previous patient. Fluorescein shows the increased transmission of choroidal fluorescence through the atrophic flecks and through the atrophic macular lesion, with no dye accumulation beneath pigment epithelium or sensory retina. Late in the angiogram, the flecks may hold some dye molecules, but they do not change in size or shape. Slide 87. Best vitelliform dystrophy. Best dystrophy is an autosomal dominant condition affecting both eyes. The earliest ophthalmoscopic finding is a thick yellow macular lesion which resembles an egg yolk. Ordinarily, this is seen in young people who have good vision despite the profound macular disturbance. With slit lamp biomicroscopy, the lesion appears to be at the level of retinal pigment epithelium, although this has not been confirmed histologically. Peripheral retina is normal, and functional tests including color vision are also normal at this stage. The EOG light-dark ratio is uniformly reduced in all patients with ophthalmoscopic findings and in obligate carriers of the dominant gene who have normal vision and normal fundi. We postulate a deposition of abnormal material within the pigment epithelial cell which blocks choroidal fluorescence as illustrated in the sketch upper left. This patient is 7 years old and has 20/40 vision in each eye. The EOG light-dark ratio is 1.00. The right macula, upper right, has an atrophic lesion. The left macula, lower left, shows a classical egg yolk which obstructs choroidal fluorescence, lower right. Slide 88. Best vitelliform dystrophy. Sometimes the material within the egg yolk appears to undergo liquefaction. The debris settles in the inferior portion and forms a fluid level. This is called the pseudohypopyon stage. Above the fluid level, the pigment epithelium is atrophic. This patient has 20/25 vision OU despite the marked macular disturbance. Note the pseudohypopyon in the color photograph. The sketch illustrates that intra-pigment epithelial debris blocks choroidal fluorescence and that atrophic pigment epithelium above the fluid level shows increased transmission of choroidal fluorescence. This phenomenon is seen in the fluorogram of the right macula, lower left, and of the left macula, lower right. Slide 89. Best vitelliform dystrophy. Not all patients with Best dystrophy pass through the egg yolk stage. Few, in fact, actually exhibit the classic vitelliform lesion. This 15-year-old girl has round atrophic lesions in the macula of both eyes with 20/25 vision in each eye. The retina is flat and shows only atrophic changes in the retinal pigment epithelium. On a fluorescein study of the right macula shown below, these atrophic changes appear as pigment epithelial window defects. It is conceivable that this patient had typical vitelliform lesions prior to her first examination. Slide 90. Best vitelliform dystrophy. It is axiomatic that one cannot predict visual acuity on the basis of macular findings. The Best disease patients bear witness to this dictum. Here we see a 19-year-old girl with end-stage macular scars in both eyes. There is a glial nodule in the central macula of both eyes. The central photograph, taken during fluorescein dye transit, suggest the presence of a fibrovascular component. Photographs taken 10 minutes after injection on the right show that dye stains the fibroglial scars, although there was no actual pooling beneath the sensory retina. Despite the similar ophthalmoscopic appearance between the two eyes, right eye vision is 2300 and left eye vision is 2040. Slide 91. Histoplasmosis simulating Best dystrophy. The upper left photograph illustrates a yellow vitelliform type lesion which closely resembles the appearance of the egg yolk in Best dystrophy. In fact, it is a fibroglial nodule which represents an end-stage scar in a patient with ocular histoplasmosis. The photograph was taken in July 1971. The upper central photograph, taken in January 1971, illustrates a hemorrhagic macular lesion with a choroidal neovascular membrane and surrounding subretinal and subpigment epithelial hemorrhage. The upper right photograph, taken in February 1971, shows considerable resolution of the hemorrhage and formation of an early fibroglial scar. Lower left is the appearance of the left macula in April 1971, when most of the blood has reabsorbed. Lower center, we see typical atrophic lesions of presumed ocular histoplasmosis, and lower right, note the choroidal neovascular membrane in the macula of the right eye. Indirect ophthalmoscopy would pose no problem in the differential diagnosis between Best disease and ocular histoplasmosis in this patient, although examination of the left macula alone might make one consider the possibility of Best dystrophy. Slide 92, cone degeneration. This is a 20-year-old white female whose vision went from 20/20 to 2200 in both eyes over a 3-month period. It is important to elicit in the history that she sees much better in dim illumination than in bright illumination, in contrast to most patients with retinal diseases who see better with increasing degrees of illumination. Color vision is markedly reduced in both eyes. Ophthalmoscopically, one sees a ring-like pattern of atrophic pigment epithelium in the macula of both eyes. In the angiogram, these are seen as pigment epithelial window defects. Histologically, there is marked loss of cones and atrophy of retinal pigment epithelium in the macula, shown schematically in the artist's drawing. There is no known treatment. Slide 93, choroidal melanoma. Choroidal melanoma is the most common primary intraocular malignancy. Ophthalmologists have shown renewed interest in this tumor because of new diagnostic techniques, including P32 and ultrasound, and new concepts regarding therapy, including the view that small tumors can be followed photographically. Many authorities believe that the clinical judgment of experienced observers remains the best diagnostic test. This patient is a 19-year-old white female who noticed a blur in the right eye and was found to have 20/30 vision. Below the right disc, there is a solid green elevation approximately 8 disc diameters in size. With a fundus contact lens, one could appreciate a significant serous detachment of the sensory retina overlying the mass. 10 seconds after dye injection, upper right, notice that the retinal vessels in the elevated sensory retina are not in focus, as are the retinal vessels in non-detached retina. 30 seconds later, note an independent choroidal circulation within the mass, lower left, with late leakage into the subsensory retinal space, lower right. Although there is no fluorescein angiographic appearance pathognomonic of choroidal melanoma, the independent choroidal circulation with late leakage beneath the sensory retina is characteristic. This eye was enucleated, and histologic examination showed a mixed cell melanoma. Slide 94, choroidal folds. Choroidal folds may occur with orbital tumors, inflammatory pseudotumors, hyperopia, or from no apparent cause. The ophthalmoscopic and angiographic picture may be quite profound, with alternating streaks of hyperfluorescence and hypofluorescence from the choroid. Schematically, one sees that in the valley of the folds, the pigment epithelial cells are crowded together. As a result, there is hypofluorescence in these areas. Along the peaks of the folds, pigment epithelial cells are somewhat spread apart, resulting in hyperfluorescence in these areas. This 22-year-old girl with 20/20 vision, a refractive error of +2 in each eye, and no systemic disease, was found to have choroidal folds on routine ophthalmoscopic examination. Despite a complete ocular and systemic evaluation, no apparent cause was found. She has remained asymptomatic over a 5-year follow-up. In the color photographs, note the horizontal folds through the left macula and the peripapillary folds concentric to the right disc. Both horizontal and circumferential folds are more readily apparent on the fluorescein angiogram. The artist's sketch illustrates the explanation for alternating areas of hyper and hypofluorescence. You have now completed a preliminary course on fluorescein angiography and macular disease. The next 6 slides will test your progress thus far. A clinical history will be given for each slide. Please write down the diagnosis, principal fluorescein findings, visual prognosis, and what treatment, if any, you would recommend for the patient. After viewing slide 100, return to slide 95 for a discussion of these 6 test slides. If you missed any, you may wish to review the appropriate section in the course. Slide 95, Self-Assessment Quiz, number 1. This is a 47-year-old white lady who complains of metamorphopsia in the right eye of 1 month's duration. The upper right fluorescein frame is taken 10 seconds after injection. Lower left, 30 seconds after injection. Lower right, 20 minutes after injection. Please write the diagnosis, fluorescein findings, and what type treatment, if any, you would recommend for this patient. What is the visual prognosis? Slide 96, Self-Assessment Quiz, number 2. This 62-year-old white male lost central vision in the left eye 10 years ago. He now presents with a sudden drop in right eye vision. Acuity is 2200. Give diagnosis, fluorescein findings, and recommended treatment. Slide 97, Self-Assessment Quiz, number 3. This 45-year-old white lady noticed a sudden change in vision in the left eye. Acuity is 2015 right eye and 2030 left eye. Upper left is a red-free photograph of the left disc macula region. The fluorescein photographs above and lower left are taken of the left eye. Lower center is a color photograph of the right disc, and lower right is a fluorescein angiogram of the right disc. What is the diagnosis, and what are the principal fluorescein findings? What treatment, if any, would you recommend? Slide 98, Self-Assessment Quiz, number 4. This 75-year-old white man noticed a sudden loss of vision in the right eye. Acuity is 20/30 right eye and 20/20 left eye. The color photograph and all fluorescein photographs, except the one in the lower right corner, are of the right macula. The photograph in the lower right corner is of the left macula. Write down your diagnosis and the principal fluorescein findings in each eye. Slide 99, Self-Assessment Quiz, number 5. This is a 12-year-old boy with 2200 vision in both eyes. Upper left is a color photograph, and upper center is a photograph taken in red-free light. The remaining 4 photographs are of the posterior pole, all in the right eye. What is the diagnosis? What is the probable inheritance pattern? And what treatment, if any, would you recommend? Slide 100, Self-Assessment Quiz, number 6. This is a 63-year-old white lady who has noticed a recent decrease in vision in the left eye. What is the diagnosis? What is the visual prognosis? And what treatment, if any, would you recommend? When you have completed your answer, please return to slide 95. Slide 95, Self-Assessment Quiz, answer to number 1. This patient has a classic serous detachment of the retinal pigment epithelium. There is a blister of elevation seen on the color photograph. There is uniform pooling of dye beneath the pigment epithelium. seen 10 seconds after injection, upper right, and 20 seconds after injection, lower left, with persistence but no change in shape or size 20 minutes after injection, lower right. There is no evidence of choroidal neovascularization. No treatment is recommended for small pigment epithelial detachments. This patient has maintained 20/25 vision over a 4-year period. Slide 96. Self-assessment quiz. Answer to number 2. This patient has classic presumed ocular histoplasmosis syndrome. The color photograph shows a hemorrhagic lesion caused by a choroidal neovascular membrane with subretinal blood. The filling pattern of this choroidal neovascular membrane is seen 15 and 20 seconds after injection, upper right and lower left respectively. In both the color photograph and the fluorescein photograph taken 20 minutes after injection, lower right, no peripapillary atrophy and the atrophic histospot. Because the choroidal neovascular membrane is beneath the center of the fovea, photocoagulation treatment is not recommended. Slide 97. Self-assessment quiz. Answer to number 3. This patient was referred with a diagnosis of presumed ocular histoplasmosis because of the hemorrhagic lesion in the left macula. However, ophthalmoscopy reveals classic angioid streaks emanating from the disc in both eyes. There is a choroidal neovascular membrane in the papillomacular bundle of the left eye with a lacy filling pattern seen in the upper center photograph, further filling upper right, and pooling beneath the sensory retina 30 minutes after dye injection, lower left. One can appreciate subtle angioid streaks around the right disc, lower center. These are more readily seen in the fluorescein angiogram, lower right. No treatment was recommended for this patient, although we have successfully obliterated choroidal neovascular membranes in patients with angioid streaks on several occasions. Slide 98. Self-assessment quiz. Answer to number 4. This man has senile maculopathy with a classic choroidal neovascular membrane in the right macula. The left macula shows drusen, which appear as pigment epithelial window defects on the fluorescein study lower right. In the fluorescein frames above, note the lacy filling pattern of the neovascular membrane. Lower center, approximately 30 minutes after injection, note how dye has leaked into the subsensory retinal space. No treatment was recommended in this case. Slide 99. Self-assessment quiz. Answer to number 5. This is fundus flavimaculatus, or Stargardt's disease. The atrophic macular lesion and the atrophic flex throughout the posterior pole are visualized as multiple pigment epithelial window defects on the fluorescein angiogram. Note that 30 minutes after dye injection, lower right, some fluorescein molecules remain in the flex. Most patients with fundus flavimaculatus show autosomal recessive inheritance. There is no known treatment. Slide 100. Self-assessment quiz. Answer to number 6. This lady with 20/60 vision has a classic form of surface wrinkling retinopathy or pre-retinal macular fibrosis. Most patients with this disorder are beyond age 50. Most have posterior vitreous detachment, and few suffer serious visual disability. Fewer than 15% go to 2200. The pre-retinal membrane can be seen in the color photograph inferotemporal to the fovea, and the fluorescein angiogram clearly outlines the markedly tortuous retinal vessels. If you have misdiagnosed any of the preceding 6 cases, please refer to the index to see which areas should be studied further. We hope you have enjoyed this presentation and that you will continue to enjoy further volumes in this Sights and Sounds series.